Thanks again for joining us for our virtual forum today, Nurturing Recovery, Navigating Treatment Challenges for Pregnant Patients. We are pleased to introduce our presenter today, one of Brightviews medical directors, Dr. Greg Johnson. Dr. Johnson?
Good afternoon, everybody. Hopefully you can hear me. We're good?
Yes, we can hear you.
Thank you. All right. So they asked me to tell a little bit about my background, so I'm not going to read all this to you. You can look at it later. So let's talk. The most important thing is why we're here. Next slide, please. All right. So I don't know how many of you remember this. This is was considered quite a provocative picture back in the day. It was Demi Moore from 1991 Vogue magazine. She's about 34 weeks pregnant here with Bruce Willis's child. And the reason I posted this is, people ask me, why did you choose OB? What was the reason for that specialty? Well, I'll tell you, interestingly enough, when I was going to medical school, my initial choice was to be a trauma surgeon. I'm an adrenaline junkie. I like to have crazy things happening fast. And that's where I started until I did my OB rotation. And what I discovered was that this was a very unique specialty. It's the only specialty in which I have to think of two patients all the time versus just taking care of the individual. In addition, OB is sort of like flying. It's hours of boredom followed by moments of pure terror. And that fed my adrenaline junkie. So therefore, that became my specialty. So how does that translate into getting involved with addiction? So back in the late 70s and early 80s, where I was at, I trained in Akron, Ohio. There was a marked increase in a thing called T's and blues. I don't know how many people are familiar with that or not. But T's and blues standing for toluene and triphenylalamine. It was a early first generation antihistamine. And what was being done is if you crushed those and dissolved them and then shot them, you would get a fairly significant narcotic effect, similar to heroin. Heroin was in short supply at the time, so we began to see that. They could shoot it IV, but most of the time it was done under the skin, and they called skin popping, and it would get these terrible sterile abscesses, and they were all over. It was just awful. So what happened is that I was, this is about 1982, and I'm in my third year of residency, and we got called to the emergency room to see a woman they brought in who was picked up for prostituting. And she was covered with these abscesses. And at the time, I wasn't familiar with it. I didn't know what it was. And I also was about 34 weeks pregnant, about same as Demi Moore here. So we ended up admitting her. Thankfully, I had an excellent maternal fetal medicine specialist who was well trained in addiction. And we began to take care of her. We got her on methadone, got her treated. Got her abscesses cleared up, treated various sexual transmitted diseases she was dealing with. And of course, I'm going to be the savior. And so I have a shining armor and a big white horse, and off we go. And we do all these things for her, and she's with us and eventually delivers. Baby's healthy, everything's great. And we took up collections for her for baby clothes, and we got her a car seat and all these things hooked together. And eventually made arrangements. She was going back to New York where her family was. Put her in the taxi cab to take her to the local bus station. And we thought, wow, we're doing great. Well, unfortunately, the story doesn't have a happy ending. About 3 or 4 hours later, I get a call from the Akron Police Department. She had abandoned the baby in the bus stop and had left and apparently gone back to New York. There's a little more to the story, and that is that approximately a year and a half later, I happened to be on call. I was chief resident then, so I'm running the show. And she shows back up in the emergency room, term pregnancy, in labor, very high as a kite, and in a breech presentation. So we ended up having to do an emergency C-section on her, which we did. This baby did not do as well, had significant withdrawal problems. I never found out what happened to this patient. Based on her lifestyle, unless she got turned around, I'm sure she died with the amount of drug usage she had. The reason I tell you that story is that this is, again, 1982, with a not real educated doc who went on to learn a lot more along the way. And what was missing in our care in this particular patient was a couple of different things. One, we had really no counseling. We thought, oh, this is an acute problem. We're going to treat her. She's going to wonderfully want to be pregnant and wonderfully want to be cured. And this was going to turn out really great, right? And we had no long-term care for her, no long-term plans. We figured, oh, we've saved you. We also didn't talk about contraception with her very much. Ended up with that second pregnancy. It was not really desired. So this is where this is why I got interested in addiction medicine partially and kept going. Can I have the next slide, please? All right. So these are simple housekeeping things. These are what we're supposed to be talking about today. You can read those. I'm not going to run through them. Let's go to the next slide, please. All right. So here becomes the next thing. So when a woman becomes pregnant and she's using, I've heard this so often, wow, you're pregnant. That should be enough. If you really love your baby, you're really going to stop using. What's wrong with you, right? So those are unrealistic expectations. This is a disease, and it's a true disease process. And to understand that, I'm going to give you a real simple example to understand addiction. So my Addiction 101 story, trying to explain this to non-addicts. So if I took any of you out to the desert, I left you there for 3 days and no food, no water, no shelter. And then I showed up and I brought you a bottle of water. And I said, hey, you want this bottle of water? Do you think you want it? Heck yeah, you want it. And I say, okay, I'm going to give you this bottle of water, but hey, give me your car keys. Will you do it? Darn right you will. And then I say, hey, how about give me your house? Give me your money. Give me your family. And I guarantee you, you will do it. Okay? Because it's life or death. I have no choice. And that's the same thing that happens with people in addiction. They don't have a choice. They may have had a choice to start the process, but once they're into the realms of it, they no longer have a choice. And so to say those types of things, hey, if you really love your baby, you'd stop using, just is not a realistic thing. It's just not going to happen. I talked about all the things that happened. Next slide, please. I'm sorry. Okay, so I talked about what happened to me in 1982. Thankfully, since that time, we've got some really great things have come along. These are government-supported programs, Comprehensive Addiction Recovery Act, with special aspects of that for women and children. Okay, so we've made a big impact in terms of money, in terms of what we do. When we talk about this, we want to also talk about the incidence of the disease. Next slide, please. Okay, so if we look at this, I'm not sure exactly where this slide came from in these numbers. I couldn't identify that, but I'm going to assume they're relatively recent. So when I started looking at this, 10.2% drank alcohol, 7.5% use illicit drugs. Well, what does that mean in terms of real numbers? So in 2024, there were 3.62 million births in this country. So if we say 10% drank alcohol, that works out to about 362,000 births, right? And well, what does that mean? 362,000, is that a big number or whatever? Well, that's the population of Cleveland, Ohio right now. So it gives you some idea about how often this is. And when you say 10.2% drank alcohol, was that one drink or 20 drinks? We don't know, right? But I guess the next question is there a safe level of alcohol use in pregnancy? And the answer is no. There's no safe level. Surely there is no question that if I have one glass of wine, not knowing I'm pregnant, that I do some terrible harm. No, because we know these things are dose related and time of pregnancy and that kind of thing. But again, there's no safe levels. But again, the reason I quote these numbers to show you the amount. Again, the same thing for 7.5 use of illicit drugs. That works out to about 271,500. patients, which is roughly the population of Toledo, which is the fourth largest city in the state. So trying to understand this is to get you to understand the extent of the disease and why it's important that we need to try to provide care for these patients. Next slide, please. All right, so when we talk about use of drugs in pregnancy, one of the things we have to be clear of is that some patients have the idea that if I've used it all, oh, it's all over, it doesn't matter, the harm is done, and what do I care? I'm just going to keep doing what I'm doing, right? Well, of course, that's not true. We know that roughly 50% of pregnancies are surprise pregnancies. That's true across all people, not just our patients with use disorders. And I would venture to say that it's probably higher in those patients that have use disorders because generally they don't have good care. Generally, because of the use of their disease, they have irregular menses. Generally, they're not practicing safe sex. So all these things lead to these consequences. Again, if I've used it all, is my baby harmed? And the answer is no. There's absolutely no question that it's the amount you use, it's the frequency that you use, it's the timing of the pregnancy. Remember, it's in that first 13 weeks of organogenesis when the fetus is developing that it's the most likely to be harmed by use of drugs. There are still ongoing things later on with continued use, so it doesn't excuse, hey, if I don't use for the first trimester, it's okay. No, that's not true. But that's the most critical time. So we have to look at all these things, and when we see these patients, reassure them, look, that the effects are not guaranteed. It doesn't always happen. Two, the extent of it depends on how much and how frequent. And if we can get patients to decrease their usage early on, it will benefit the child in the long term. Next slide, please. All right. So this is what we're talking about, what we're going to do when we try to see pregnant patients when they came in. The most important thing we can do initially is to get them into prenatal care. The earlier, the better, so oftentimes we have no idea about gestational age. And if we can get them in to see an OB care frequently, we can get an early ultrasound, we can determine gestational age, which will help us long term. As with everything, the earlier you do the ultrasound, the more accurate it is. So we would try to do that as quickly as possible. And then the next thing, of course, is get them in addiction treatment. We'll come back and review that in a minute. Of course, in addition, do we have safe housing? What about security? What about long-term planning for what we're going to do with this child? These are things we need to evaluate. And again, I told you we treat two patients, so we have to talk about the fetus. So we need to think about what we're going to do with the management of NAS and NOWS and safe care of the child afterwards. You know, when I looked at the terms NAS and NOWS, it stands for neonatal abstinence syndrome and neonatal opiate withdrawal syndrome. And I have to be honest with you, in my mind, initially, I kind of thought those were synonymous or interchangeable. It turns out really they're not, you know. Neonatal abstinence syndrome refers to any substance, where NOWS refers to neonatal, opiate withdrawal syndrome. So it's very much more specific because that tends to be worse. But we have to remember we have withdrawal syndromes for essentially all substances, depending on the extent of usage. The other thing that was very interesting is the extent of variability with NOWS. And we looked this up to try to decide what, help us to just understand the frequency. And turns out that if you look at the incidence of NAS by state, the lowest is in Hawaii. It's 1 in 1,000 births. The highest is West Virginia, 43 per 1,000 births. I mean, this is an incredible amount. The rate has been from 2000 to 2012, the rate increased by 383%. And from 2010 to 2017, increased another 82%. So what does that tell us? It tells us, hey, that there's a significant incidence of use of disorder, which we basically have already defined by the numbers we looked at earlier. Again, the extent of NAS development, as we talked about, it depends on the drug that you use, the quantity, the duration, the gestational age at which that was started. There are individual genetic factors. This is we know with the addiction. Genetics plays a significant portion. It also has the effect on the fetus depends on that. And the biggest factor that's one of the most serious things we have to deal with is polysubstance use. Next slide, please. Here's a chart that we use for NASA now scoring. I expect you to memorize this, but this is what the nurses will be using when they're in the NICU. And they help to determine the extent of it based on that score. How much does the child need treated? Does it need medication? Or can it be done just with soothing? The incidence overall, the number of babies actually end up going to the NICU is actually, not they go to NICU, but rather that need medical treatment is actually pretty small. The majority of the time, this can be done just with soothing techniques. Next slide, please. Oh, this really wasn't what I wanted. Okay, let's move on. We'll come back and talk about techniques of how to treat NAS. So we now have our patient. She's come in. We've established that she is pregnant. We are helping her get prenatal care, housing, all those things we talk about. What do we do in terms of treatment for opiate use disorder? So we have three options of treatment. We can use buprenorphine, we can use methadone, we can use naltrexone. Up until, in the past, there was a study done in around 2005 to 2008 called the Mother Study. And it was looking at the use of buprenorphine in pregnancy and the safety of it. And when that study was published, it stated that buprenorphine indeed was safe for pregnancy. It did work well. It significantly reduced complications for mother and for child. But it also suggested that the majority of that study was done with buprenorphine alone, and they had didn't say you couldn't use the combination product of buprenorphine and naloxone, but the way some people interpreted that study, it would suggest that you had to use simply naloxone, or simply buprenorphine. And that kind of got perpetuated, and that was going on for some time. Now, from people like myself who are double boarded, I went, this doesn't make sense to me. I mean, why would I want to do that? It doesn't really help. Doesn't make sense because we use naloxone frequently in recovery of babies. Again, I'm trained in the old days when we still gave narcotics for pain control during labor. And oftentimes these babies would be born and they would be a little floppy and a little hard to get them initiated to breathing, and we would give them naloxone intravenously through the umbilical cord, and they would perk them right up, and off they went. One thing I didn't understand back in those days was the relatively short half-life, and I wonder what happened to those babies after they went to the nursery and about 30 or 40 minutes later. But again, that wasn't my job in those days. So anyway, knowing that we'd used this for years, it didn't make sense that combination product should be an issue. But again, it was because of the mom study and the way it was written, people sort of misunderstood that. There has been recent data published in the last 4 or 5 years that have actually looked at the use of the combination product. And it turns out that babies actually do a lot better. I shouldn't say a lot better, but do better if they are actually moms were treated with a combination product. So their incidence of NALS is much less with a combination product versus a mono product. So current standard of care at this time should be a combination oral product. What about the injectables? Are they safe? Do they work? There was a question about Sublocade in the past. It contained a product called NMP. Don't ask me to pronounce the whole chemical name, but it was a way of stabilizing the product, and it was associated with some abnormal development in animal studies. And there was questions about it. However, most recent data seems to show that that really isn't a significant risk. But again, and it is not contraindicated for use in pregnancy. So Sublocade can be used. But I would, if patients question it or there's anything, I would at least counsel them, hey, there has been this questions in the past. It does not appear to be a problem, but I need to make you aware of that. Brixadi has never had that issue because it doesn't have that stabilizing agent. So yes, it can be used. What about methadone? So way back in the day, when I was starting all this, all we had was methadone. Buprenorphine wasn't available at that time. And we used it a lot, and it does work. And there's nothing wrong with methadone. I talk to patients and try to explain to them, hey, what are your options? What do we do? I present it in this fashion. And that is that both of these are A drugs. But buprenorphine is an A plus, and methadone's an A minus. And what's the A minus mean? That there is a little higher incidence of withdrawal syndrome in babies that are moms who are exposed to methadone. But again, it's minor. They generally do very well and don't need, generally are not need medication for it. But there is a little minor difference that we need to talk about that. And again, make patients aware of that. And again, when I counsel them, if they choose methadone, I will make sure I always document the chart. Yes, this is not what we recommend routinely, but this is, but it is a safe product to be used. Naltrexone certainly can be used. Again, no significant complications in pregnancy that we know of. The beauty of it is also there's no dependence on it after delivery. Next slide, please. All right, so here's what we were talking about earlier, NAS and NOWs. As would be suspected, they have a higher incidence of sudden infant death syndrome. This may be due to auto dysregulation, it may be breathing issues, maybe environmental. There's all these, you can read the list. I won't sit here and explain it all to you. But we need to be aware of that. And that goes back to having the education of our patients, proper sleeping technique, the old back to bed versus don't put them on their stomachs. And working also with our pediatricians that they are aware of it. Next slide, please. And here we go. Here's the instances I told you earlier. They say up to 5.8 per 1,000 births, unless you live in West Virginia, then it's 43. And again, as we already discovered, will use always cause withdrawal symptoms? No, not at all. Depends on dose, some quantity, frequency, and the most recent use. Also, with the use of treatment of buprenorphine or methadone, the incidence is significantly reduced for patients to develop it. Can they? Yes, they can, but it's very uncommon and it's very mild. Next slide, please. All right, here's the next thing. Why don't, patients oftentimes don't want to come in for care. They're afraid, they're pregnant, they are concerned about, is there going to be regulatory issues? Is my baby going to be taken away from me? These are all concerns. So a little bit more about my background. So as I told you, I started my practice. I finished my residency in 1983. I was in private practice and then eventually into teaching residents in the late 2000s, or excuse me, early 2000s, did that. But I developed some serious health problems. I developed a condition called psoriatic arthritis, a small joint disease, and found out around 2007, 2008, I was having difficulty being able to operate or take care of patients. I went into a relatively deep depression because of that. Got into alcohol use disorder myself for about a year. But thankfully, I was blessed and had help from some really good folks. I went into treatment in 2010 and have been, thankfully, been sober since that time. But when I was in treatment, one of the things that I learned was spoke to one of the docs who took care of me, and I said, part of my issue was my depression, my concern for, not being able to work. And he said, well, your hands don't work anymore, but your brain works pretty good. And you do have a background in addiction. So again, I was blessed. I was able to find a addiction medicine fellowship, which I completed in 2014 and was able to get my boards completed at that time. So why do I bring that up? Because as a result of that, I was able to get a job as a medical director at the Community Health Center here in Akron. I was in Toledo at the time and came back home. Didn't really like Toledo. We can talk about that sometimes, but got back to Akron and was offered a job at Community Health Center. And when I was there, we were able to partner up with Summa Hospital, which is Akron City, where I trained years ago, and we started a program called Centering Program. It's very similar to what's on this slide, what's recommended. What we found is that pregnant women, when they would come in, were often judged harshly by the staff, by the residents, by the nurses. They also were made not to feel a part. And also they had significant primary issues, right? They're unique to them with their disease. So we started a program specifically for them to deal with this. It took a lot of education, a lot of training to both the residents and the nurses to get them to understand this is a disease and get it turned around. And it was very interesting as a few years went by. I think the first year we only had 25 or 30 patients. The next year it went to 50 or 70. And the third year was into the hundreds. And what it was, I had a patient once present to me, of course, late on a Friday afternoon, never fails. She had driven over from Sandusky and states, I learned about your program through a friend of mine. I really want to get involved. She was near term. Said, yes, we'll help you get you going. And she said, you know what? You guys are the Disneyland of care for pregnant patients. And I started laughing to myself. I thought, well, does that make me Mickey Mouse or what? I'm not sure. But anyway. But it goes to show when you start these programs and got them going, it really helped. And we did all these kinds of things as far as care prenatally through the delivery, how to manage them, how to deliver them, manage them postpartum, help them with any legal type issues they might have. We had counselors involved with this, with the patient at the same time, as well as any medical support that was needed. All right, next slide, please. All right, what about breastfeeding in pregnant or in patients with opiate use disorder? The answer is yes, yes, and yes. Okay. The benefits of breastfeeding have been noted for many, many years. In addition, some of their meds, methadone, buprenorphine, will be transferred in the maternal milk. It's very small, but it's enough that it may help prevent with the Now syndrome. It's a little unclear, but studies are all in agreement, however, that it is beneficial. So it does not cause problems with the baby long term when they stop nursing or they're going to have withdrawal. No, we don't see that. The amount they get is so small. But again, the benefits of nursing and all other aspects in terms of bonding with mother, in terms of the benefits in terms of infections and that type of thing, receiving mother's antibodies, all been well documented. Next slide, please. All right, so next thing we need to talk about is contraception. So we've got our, hopefully our patient delivered. We've got her, follow up with long-term care with the pediatrician. Now we need to talk about, what do we do in terms of contraception? We should really talk about this with every woman that comes in for care that is of childbearing age. Should we, as practitioners with Brightview, be prescribing contraception? And the answer is no. Would not recommend that. And why is that? And the reason is that really we don't have the methodology or the ability to follow these patients up appropriately. I mean, giving somebody birth control pills and sending them out is not is not good care. And these patients need an exam. They need pap smears. They need check for STDs. We have all these things which we are unable to provide. So If we see condoms, of course, we have those on site. We believe every clinic has them, and we should encourage their use. But the more important thing is, hey, what are you doing if you need care? Do you have an OB? Do you have a gynecologist? Do you have someone we can refer you to? Do you have a primary care physician? If they don't, or you live in an area where it's not readily available, most health departments will provide. I can't speak for everywhere. I can talk about Northeast Ohio, but most health departments will provide contraceptive care, and they will provide those other services that are needed. Planned Parenthood, another option. If you have that available, encourage your patients, hey, let's get there. But we can't just send them out without doing anything. We need to provide provide a list, provide names. We have to do those are the best we can do to help us out. But for us to actually prescribe it, I don't think is a appropriate thing we should be doing. Next slide, please. And we talked about this earlier, stigma. Patients don't want to come in. They're afraid of that they'll be reported. Long term, when we got with my experience that we had at the centering program, we really had no issue with children's services or anything. They were all documented that they were under care. That was all known by the medical staff, the nursing staff. We were able to allay their fears, so that was not going to be an issue. You're not going to have to be a visit by somebody coming to take your baby or whatever because you're in care. Again, back to that stigma also, you don't really love your baby because you don't stop using. We've talked about that earlier. That's not the issue. This is a disease. It has to be treated as a disease. Next slide, please. Again, these are things we discussed. Next slide. Oh, one last thing I want to say. Can we go back to the last slide? Forgot to mention one thing. Public policy. There have been over the years people have suggested, hey, we need to criminalize. If you're pregnant and you're using, that's child abuse or child jeopardy, and that we should criminalize this. And the studies have really shown long term this does not work. It's exactly the wrong thing. We drive people away, they get less care, we end up with more complications and more problems down the road. So we don't need to going in that type of public policy never works. I just want to emphasize that. It's just not a way to handle it. Next slide, please. Okay, this is where we're going with this exact thing I was just discussing. So next slide. Yeah, CPS. Next slide, please. Next slide. All right, so here's a basic plan. Here's some interested, what do we do? How do I manage this? Here's some suggestions for that. But again, the biggest thing is for us long term is to get them into good OB care, centering programs if available. A lot of hospitals have adopted this, by the way. It's not new here or unique to us. You may have to check with their providers. But these are the different methods or different ideas we may be looking for in terms of long-term safe care for the patient. Next slide. All right. The biggest thing that I would see is this building of trust. I think most all of us that are in Brightview already know this, understand this. When I was in Toledo, and this is the early 2000s, what we saw at that time was a marked increase in crack usage there. And I was at a large inner city hospital in St. Vincent's in downtown Toledo. And the OB was on the 7th floor of the hospital. And this would happen at least 2 to 3 times a week. We would get a call from the emergency room. Hey, we got a pregnant one down here. Think she's in labor. We're putting her on the cart. We're sending her up. we had a little ante room outside where the elevators would come up in the hospital, and I would get our team together, my residents, my nurses, or other ancillary staff. And we would go outside of the locked area where OB was, and we'd be waiting. And you could hear the scream at about the fourth floor, and it would get louder and louder until the doors popped open, and here would be this woman who would use crack. They were always between 20 and 24 weeks. What happens is that the use of crack or cocaine leads to abruptions, where the placenta separates prematurely from the wall of the uterus and puts them into labor. A large percentage of the time, the baby was generally already delivered, and they're so tiny, there wasn't a lot we could do. But again, being a Catholic hospital, we were obligated to try to save everyone that we could. But that really wasn't very successful. And over this would happen, the same type of thing. And I would hear from the nurses at the time, there's this building of trust is, oh, it's another addict. Oh, it's another one of those people. Or if we had somebody come in who was, an opiate, with opiate addiction, who was in treatment, they were always told, oh, these are not the kind of patients we want to take care of. And it took a long time and a lot of effort dealing with residents, dealing with nurses, and in fact, to the point where we had to actually, there was a couple of nurses that we actually had to dismiss because they just could not, have that attitude that we were not going to take care of these patients. So we have to show this to the patient right away. And I think all of you do that pretty well every day. Next slide. All right, again, this is that stigmata, that same type of thing we were just talking about. And again, you can look at this. Next slide. All right, so this has kind of been my story. I've taken care of, I don't know how many women with use disorders of various types. And it's a very satisfying experience. Unlike my initial experience, I talked to you as a young untrained resident in 1982, compared to now, where we have the whole system put together in terms of how we manage their meds, how we get them into prenatal care, how we plan for long-term postpartum care, how we plan for contraception, what are we going to do? It's a very rewarding and satisfying experience when we're able to do those things. Next slide, please. Yeah, and pregnancy is a reachable moment, as we talked about, as it states there. Sometimes it is the turning point. Sometimes it is the time when the patients will, hey, I need to look at my lifestyle, what I'm doing, but don't expect it every time. You would think so, but it just doesn't happen. Next slide, please.
All right, thank you, Dr. Johnson. We are going to go ahead with the Q&A portion of today's discussion. We are aware of some issues with the chat, and we do apologize for that. Luckily, we have some great questions that were submitted during registration that we will go ahead and use. So to kick things off, Dr. Johnson, what would you recommend as a safe option for outpatient withdrawal management for pregnant patients who may just be entering treatment?
So I'm not sure that I fully understand the question of outpatient withdrawal treatment.
Correct. For pregnant patients who are entering treatment who might be experiencing withdrawal symptoms, what are some, techniques or strategies that we can help them?
Okay. So, hopefully I understand this question properly. It'd be so much nicer if you could talk face to face, but if you're asking me, they present with withdrawal complaints, again, I would review with that patient the benefits of treatment. We'll review all the different options. So we have, whether that be with people naloxone, whether that be injectable or oral, whether that be methadone. Make sure they fully understand, because there's so many misconceptions about those meds by the lay public. And once they review that, Again, my recommendation is preferentially is treatment with buprenorphine. If they're in withdrawal, I would start them, generally speaking, again, I need to know quantity, frequency of usage, that kind of thing. But, I would do our withdrawal treatment that we normally do. I would start with 8 milligrams, review, see what they look like in an hour, follow their cows, go to 16, and go to 24 if I need to. Important point I forgot to mention is when we look at the incidence of the patients, the babies developing now, following with treatment of medications, there is no relationship whatsoever. If we use 4 milligrams of buprenorphine and we use 24 milligrams, the incidence of the now is the same. Now, there is a study, I take that back, wrong thing. And with methadone, same thing. There is a study, if you really look at deep in the literature, and I believe it was from the early 90s, was done in England, and they looked at if you gave 20 milligrams of methadone or less, they had absolutely no incidence of NOWs. It wasn't called NOWs then, but that's what they're talking about. But I don't think very many of our patients are ever going to be on 20 milligrams. So aside from that, whether they're on 50 milligrams or 200 milligrams of methadone, well, I should say actually 150 milligrams of methadone, there's no increased incidence of NOWs. There is a recently published study that suggests over 150 milligrams, there may be a slightly higher incidence of NOWs, but again, it's minor and does not generally need medical treatment. Hopefully I've answered your question.
Can you discuss potential safety concerns around a patient using marijuana during pregnancy? How would you recommend managing pregnant patients who use marijuana to treat other medical symptoms?
All right, so great question. So does marijuana have an effect on developing fetus? The answer is yes, it does. There's been some significant studies that show evidence for midbrain developmental abnormalities and long-term heavy uses of those with marijuana. Interestingly enough, you would think that there would be an increased risk for complications similar to be seen with tobacco smoking, and the answer it doesn't happen. With tobacco smoking, we see a higher incidence of IUGR, intrauterine growth retardation, premature birth, placental abruption. Doesn't seem to happen with marijuana. And I was surprised when I read those studies, because I would assume they would have been similar. So I don't know the reason why for the difference. But generally speaking, it's been my experience that the majority of patients who smoke marijuana generally smoke tobacco as well. So there may be a compound risk there that we need to talk about. Very difficult to get people to stop. At least we can try to, hey, how about cutting down? Can we use, hey, you told me you only use it for sleep. Okay, I want, small amount to help you sleep. Okay, we'll live with that. But it is not a benign drug. It does have some complications, but I have to be honest, they're relatively mild.
For many of us who might be parents, it's natural to have some strong feelings in situations where we're working with patients. What guidance do you have for probation officers or any other people in the community who might be working with this patient population to set aside those personal reactions so that we can better connect with and support pregnant clients?
All right, so we've already discussed the fact that, using criminal type things and criminalizing this disease does not work. And punishing people who are already suffering is of no benefit. So the big thing I think to get across to them is, hey, emphasize this is a disease process. Use my bottle of water, Addiction 101, try to see if you can educate people, as we discussed earlier. Explain to them, hey, look at the treatment benefits I've shown. Do they work? Try to get them involved in centering programs or things like that I discussed. And also with our counselors, use your behavioral health people. They can help you a lot too in terms of educating and dealing with with the criminal issues.
Dr. Johnson, when is direct intervention necessary when it comes to the safety of both the child and the patient? do we as providers even have the right to intervene directly?
Uh, well, I guess this goes back to the fact if obviously if we know the patient's going to harm herself, is a suicidal risk, then of course we're obligated to do something. And people have made the argument, well, if we know that meds or that drug usage in pregnancy is harmful, isn't that harming the child? Don't we have an obligation? And the answer is no, it doesn't work. We talked about criminalizations. Um, People are allowed to have some free choice in this world, and women are allowed to have a free choice in their bodies and how they manage them. So it's difficult. Believe me, I felt that frustration too, especially when we were dealing back with patients drinking a lot. That was a tough one. I really have to work hard with those patients. But now criminalizing, stepping in, sort of, unless the patient is going to harm herself, we can't do that. We can just educate.
Can you speak a little bit about maybe your experience with Child Protective Services? When does Child Protective Services become involved? Is it automatic when a pregnant patient enters treatment? Are there any mandated reporting requirements when a pregnant patient discloses a substance use disorder?
So the answer is, and I can only speak for the state of Ohio. I don't know where you guys are coming from. So outside of this state, you'll have to learn your own rules. But in the state of Ohio, no, it's not required to report these patients when they come in for care. That's a violation of our HIPAA laws. Generally speaking, if we can get them into a centering program or some type of, program at the hospital, that helps a ton because everyone will be aware of what's going on. They will be keeping the OB as well as the hospital, the counselors will be following their treatment plan, showing that they're adherent to their plan, monitoring their tox screens. And yes, there are some obligations that the hospital has to do at the time of birth. But when that happens, as long as it's been shown they're in this program and it's been shown their compliance, generally speaking, Child Protective Services are very happy not to be involved. And let's face it, they're overworked, understaffed. And if we can get somebody who's making an effort and doing all these things, they generally are not an issue.
And I think we've got one last question here for you, Dr. Johnson. This comes from someone in a hospital setting. What would you recommend, or how would you recommend approaching patients about withdrawal symptoms in infants, whether they're already happening or not? They have found a lot of the patients in the hospital are not prepared or might be confused by those symptoms, and they end up self-blaming themselves during treatment. So how can we better prepare or educate them for that?
Oh, great. Yeah, that's a great question. So again, when from what I understood of that question, they're in treatment, now their patient is, their child has developed NOWS or NAS, whichever. And the answer is, look, hopefully we've educated them early on that this was a possibility. And I'm gonna tell you honestly, all babies who are born to moms who have used opiates during their pregnancy, whether that be prescribed or illicit, will have some withdrawal. It's going to happen, and you should be educating them ahead of time. Again, counseling has already told you it's not dose related, has nothing to do with that. I've seen moms try to not go to a higher dose, fearful of harming their child. And what I usually educate them on is, hey, look, if you're in withdrawal, your baby's in withdrawal, and that's what we want to try to avoid. That's not a good thing for this child. And again, you're not going to harm them long term. And again, this is not, it's a disease process, and it's no different than the diabetic. Okay, if I'm taking care of a pregnant diabetic and we are managing her blood sugars as carefully as we can, it's still not uncommon that the baby will come out and develop episodes of hypoglycemia because they were used to being surrounded by a much higher level of higher blood sugar. And of course, that's been stopped once the umbilical cord's cut. And again, would we fault at the patient or say they did something harmful because they had a disease which resulted in a problem for their child postpartum? The answer is no. We wouldn't do that. And so we have to reassure them. This is a disease process. We know it happens. It's very mild, and generally it's treated very easily with swaddling, increased feedings, increased holding, that type of thing. And generally it passes within about 5 to 7 days. Hopefully that answers your question.
Yeah, that was great. Well, thank you, Dr. Johnson, and thanks to everyone for attending our virtual forum today. As a reminder, you'll be receiving your certificate, a link to the recording of this presentation, and a copy of the slides in a follow-up email within the next 10 business days. And we hope to see you at our next forum, Harm Reduction 101, in September. You'll receive a link to register for that event in that follow-up email as well. Have a great rest of your day.
All right. Thank you all.